Now I would like to welcome Dr. Anubhav Goyal, and he is consultant at Giridhara Institute, very passionate about ROP, and he'll be talking us about classification of ROP, what is new in treatment also.
Thank you, ma'am, for the kind introduction. So my topic is on current classification and treatment, which I already some part of it already Anand sir has discussed. So I'll be concentrating on this only. So as we all know, ROP is the most common cause of childhood blindness, and we have to do a major, we have to understand a lot in ROP, and we have to do a lot in ROP. So ROP initially was classified in 1984 with the basic classification on zone, extent and staging, which further in ROP 2 it was added AP ROP and Pre Plus was added in 2005, but because of lot of shortcomings and limitations in this classification, in innovation in ophthalmic imaging, and now the extensive use of anti-VEGF in ROP treatment and change in ROP spectrum worldwide with the larger baby presentation of ROP in larger babies. This ROP 3 has been introduced in 2021, and this classification was given under the chair of Michael Chang in 2018 with many continents contributing to this classification. So this classification has a modified explanation under 7 points. That is, AP-ROP has been changed to AROP, ROP regulation, which is a new terminology, ROP reactivation, and PAR. These are 3 new terminologies. They have redefined stage 5, and then they have redefined zone 2 and plus disease spectrum. I will be discussing all this. So as sir has already informed, AP-ROP has been termed as AROP. It's more as the aggressive ROP because now more of the babies are seen with this aggressive ROP. Table showing difference between ROP 2 and newer terminology between ROP 3. This reactivation, regression, and peripheral avascular retina, which is introduced as a new terminologies in ROP 3. While coming to management, the most important part of management is still the screening. We have to concentrate on screening because it's a very important thing and it has a lot of medical legal issues. Treatment comes next to it. As sir has already explained, this is the standard new guidelines of screening the babies. And coming back to treatment, the first initial treatment for ROP was cryotherapy by cryo-ROP we get to know in 1988 because of lot of unfavorable outcomes which was not followed now. The second landmark trial came as AT-ROP, which shows the importance of laser in treatment in ROP, which shows decrease in unfavorable anatomical outcomes from 27% to 9% in 27% in cryotherapy to 9% laser treatment, and then anti-VEGF, which can be used as monotherapy or adjuvant therapy to laser or as a pre-operative treatment before surgery. This has further changed the whole spectrum of treatment and has reduced and has shown the benefits of treatment with significantly less unfavorable outcomes. So in the next slide, you see the unfavorable outcomes has reduced from 22% cryo-ROP to AT-ROP 9% to beta-ROP just 4%. This injection, anti-VEGF injection is very good, but there has some shortcomings. AT-ROP has also defined classification into high risk threshold and low risk threshold. So the high risk is type 1 ROP, which needs treatment. Low risk is just to be screened, not to be treated. So this is now well known and documented that zone 1 has to be treated with injections because the outcomes are better, and zone 2 has to be treated with laser, and laser in treatment in zone 2 has better outcomes. There are a lot of studies which are showing multiple anti-VEGF treatment benefits of ranibizumab, aflibercept, along with bevacizumab also. Rainbow trial is a recent landmark trial which has shown the benefit of ranibizumab superior to laser treatment for a treatment of ROP. So this laser is still the gold standard treatment, and this is showing our case in which you can see after the this stage 3 peripheral avascular retina, laser marks has been given with near confluent burns. Anti-VEGF and laser has a difference. Anti-VEGF causes significant vascularization to the periphery without leaving much of damage or scarred peripheral retina, but laser causes significant scarring in the peripheral retina, which has further sequelae and complication in long later life. The The major problem of anti-VEGF is it can have later recurrences as low as is shown the 60, beta ROP shown that it can be by 16 weeks, but it can show as late as 1 year also. So very close, careful, long-term screening and follow-up is necessary after, especially after injection. Laser treatment is still the gold standard treatment for ROP. If you know the laser, there is the best treatment, especially for zone 2 ROP. Still, most of the doctors should, as our current guidelines, following anti-VEGF followed by laser treatment as a rescue treatment 2 to 3 weeks after the laser treatment. Once the zone 2 posterior vascularizes to save maximum part of posterior bone. Now come the posterior surgical management. Surgical management is divided into basically is basically of stage 4 and stage 5. Stage 4A is does well with buckling and vitrectomy is ready for 4B and 5. So take home message, early screening and timely treatment plays a major role in ROP screening. ROP to be examined every 1 to 2 weeks until vessels mature and disease threshold are passed away. Treatment includes later treatment, anti-VEGF and surgery for stage 4 and 5. Thank you.
I have a question. So you spoke about avascular. Is it seen in the babies which are treated only with anti-VEGF?
Yes, sir.
Not in babies.
Actually, sir, in normal vascularization of retina, major vessel and myelin branches grows simultaneously. But after anti-VEGF, we usually see major vessels growing, but small vessels might lag behind in peripheral vascularization. So that vessels which are minor vessels which are lagging behind is the reason of peripheral vascular retina.
But the standard of care is still, even if you're giving anti-VEGF.
No, sir, it's not the
laser.
standard. Laser is the standard.
That's what I'm
of care.
saying.
Yeah.
Even if you give anti-VEGF,
Yes,
laser
sir.
is given later.
Yeah.
It's not that only anti-VEGF is
No, it should not be given. Laser injection should be followed by laser once the posterior zone 2 is vascularized. At least posterior zone 2 has to be vascularized.
To lecture on ROP, new classification and management.